Good morning, everyone. I'm so delighted to introduce Dr. Joy Hawkins this morning, who is our first visiting professor for this academic year. Dr. Hawkins hails originally from Texas and completed her undergraduate and medical school education at Texas A&M before moving to the University of Texas in Houston for her anesthesia residency. She stayed in Houston for a one-year combined OB and critical care fellowship at Baylor, and then stayed on there as faculty until 1992, when she made the huge leap out of Texas to the University of Colorado in Denver. Shortly after her arrival there, she assumed position of Director of OB Anesthesia, which she continues to serve in that role. And she's presently a professor of anesthesiology there, and also serves as Vice Chair for Education and the Residency Program Director. For over 20 years, Dr. Hawkins has been shaping the field of OB anesthesia as the chair for the ASA Task Force on practice guidelines for OB anesthesia. She's championed safe and effective care, always searching for the evidence amidst the constantly changing landscape of OB care. She served as president for the Society of Obstetric Anesthesiology and Perinatology and was honored for her contributions to the field with a Distinguished Service Award in 2016. While OB is her passion, she holds leadership roles promoting all aspects of anesthesia and is the current president of the Colorado Society of Anesthesiologists and is chair of the board of directors for the Foundation for Anesthesia Education and Research. Please join me in welcoming her, as we are so honored to have her here today to give her perspective on the controversies in OB anesthesia care.
Well, thank you so much for having me. As I mentioned, I've never been to UCLA before and probably landed in LA twice in my life. And so it's been a really nice visit to get a chance to look around at your beautiful campus. I've really enjoyed myself. I changed the title a little bit, as you can see, to myth busting, which is one of my favorite things to do, is to look back and say, now, why do we do this exactly, and where did that come from? So we're going to kind of hop, skip, and jump through a lot of different aspects of OB anesthesia practice and look at some of the ways we do things and how the literature is letting us re-examine those and think a little harder about what we do and why. Roughly, it's going to be organized into a policies and procedures kind of a section, how we do labor analgesia, how we do C-sections, and then just a little bit about management of complications. So let's start first with policies and guidelines. If you end up being the person in your group who's going to be writing the policies for your hospital about here's how we do things, you want to make sure you can present that to your obstetric colleagues with some evidence behind it. So one of the things that comes up frequently when we're going to see a healthy woman who would like to have a labor epidural for her analgesia is, what laboratory tests do we need? What studies do we need to wait on before we can do a neuraxial anesthetic? And the answer to that is none. And there are still practices that want to see a CBC and want to see a platelet count before they're going to do an epidural. So if you go to the ASA practice guidelines on OB anesthesia, in the section on pre-op, it says you should order or require a platelet count based on a patient's history, physical exam, and clinical signs. Same way we order lab tests on everybody else. But a routine intrapartum platelet count is not necessary in the healthy parturient. Well, what about preeclampsia? We always want to see labs on our preeclamptic patients, right? So this study looked at what is the frequency of lab abnormalities in women with preeclampsia. They found that overall, all comers, about 7% of them, are going to have abnormal labs, but it's only 5% if they have mild hypertension, or what we now call preeclampsia without severe features, 9% if their hypertension severe, and goes up to 12% in the women who also have signs of end organ dysfunction. So you can risk stratify who you might want to get lab testing on. So in women with mild hypertension, you might say, we don't actually need to see any labs because 95% of the time they are going to be stone cold normal. Not a very cost-effective way to do testing on everybody. Well, is there some platelet count we're going to get back that's going to predict complications and make us say, no, we can't do an neuraxial block on her, or the how low can you go question? And our obstetricians always want us to give us a concrete black and white number, right? How low can her platelet count be and she can still get her epidural? And the answer to that is no, there is no such platelet count. And how low can you go? Well, it depends. So there's no laboratory test that we have now, platelet count or otherwise, that predicts bleeding into the epidural space. Platelet function is really what we want to know, and we don't have that test, or not a good one at least. So what you want to know is diagnosis. Why is her platelet count low? If she has gestational thrombocytopenia, her platelet count is really almost irrelevant because those platelets work just fine. If she has ITP, which is not uncommon in this age group, she's got super platelets. Those are the biggest, fattest, stickiest platelets out there, and they work great, and you might be willing to go even lower than you normally would. HELP syndrome, on the other hand, very dynamic disease. Things change fast, unpredictable function of those platelets, and you don't want to go very low. So across the board, I would say most people who do a lot of OB anesthesia are fairly comfortable about going down to 75,000. And you notice I have comfortable in quotation marks that because, no, we're not really comfortable. But if there's no clinical signs of bleeding and that count's stable, we're probably okay. If you have access to thrombolastography or to ROTEM, that's great, but you still have no cutoff that you can say, whoop, that's it, she's too low, we're not going to do that block. Now, I showed this to the residents yesterday when we were talking about morbidity, mortality. This was a big, big, big review, 1.7 million spinals and epidurals looking at complications, all comers, OR, and labor and delivery. More female patients had complications than male, and surgical patients more than OB patients. So already the OB patients are somewhat protected. But they did find 2 neuraxial hematomas, and that's our big concern, right? That's what we're worried about. And those were both in HELP syndrome patients. So there's something different about that disease that we want to be more cautious, and maybe we don't want to go below 100,000 or something even higher. So each patient who has a borderline platelet count, you're going to be balancing risk-benefit ratio. So what's going to push you to say, yep, I'm okay with this, we'll go ahead and put in her epidural or her spinal for her C-section? Well, if she has one of the good diagnoses, so she has gestational thrombocytopenia or ITP, that's going to make you more comfortable. If her airway exam looks horrible and you don't want to have to intubate her under any circumstances, if she's 1 centimeter and we're looking at 12, 18, 24 hours of pain control she's going to need before her delivery. And remembering, again, the rarity of an epidural hematoma. It is a very, very, very uncommon complication. Now, what's going to push you to say, nope, no way, no how, I'm not going to do a neuraxial anesthetic in this patient. She's getting an IV PCA for her labor, or she's going to have a general anesthetic for her C-section. Well, that would be the woman who's got oozing around her IV sites, the one who had a 300,000 platelet count yesterday and it's 100,000 today. And if you're going straight to the OR anyway and her airway exam looks great, why not just put her to sleep and not even worry about the consequences there? So if you do choose to do a regional anesthetic and your labs are borderline, do something short-acting so that you can start doing neuro checks as soon as possible once the case is done. Skin prep solution. That's been a big change for us recently. Those of you who put in a lot of central lines remember transitioning from betadine preps to chlorhexidine not too long ago, and we're in the same situation now. So chlorhexidine alcohol has become the go-to appropriate skin prep for us too. ASRA put out a consensus statement about prevention of infectious complications a few years ago. And one of the things they said is that alcohol-based solutions will provide the maximal degree of antimicrobial activity and with extended duration when compared to others. And that was grade A evidence. A distinct advantage of chlorhexidine is that it adheres to the stratum corneum. You can't get it off, and therefore its antimicrobial activity goes on for several days. So in a letter to the editor to the Anesthesia Patient Safety Foundation newsletter, somebody wrote in and said, well, okay, ASRA guidelines and APSF have both come out and recommended chlorhexidine as the antiseptic of choice for neuraxial procedures. So why does that applicator package still say it should not be used for lumbar punctures and not be put in contact with meningeal structures? So they referred that to the makers of chlorhexidine and say, okay, why is this? And they came back and said, well, you know what, if you go look at that betadine solution, it says exactly the same thing, yet we've been using that for years without worrying about it too much. From the perspective of the manufacturer going to the FDA to get that label changed, it is cost prohibitive. These complications are so rare, it would take a millions of person study to prove that there was a difference, and they're just not going to do that. So from the perspective of the manufacturer, the expense of getting that label change is just prohibitive, and it's not going to happen. So just a few months ago, the newest guidelines, which ASHRAE and ASA have now combined on for prevention of infectious complications, came back out and continues to say all the things from before, take off your jewelry, wash your hands, wear a mask, and use chlorhexidine with alcohol as the antiseptic of choice, which means you're going to have those separate applicators available because they will not be in your epidural trays. Postpartum tubal ligations on labor and delivery have always kind of been the poor redheaded stepchild of procedures. We sort of get to it if we can, but if not, we don't worry about it too much and we send them home. So is that appropriate? Should these be considered elective cases? No, they shouldn't. We should consider them urgent cases, and we should push really, really hard to get them done. So why is that? Well, what happens to a patient if she requests a postpartum tubal and it doesn't happen? She got fed breakfast, the deck's busy, we don't have enough personnel today to get it done. So this study took 3 cohorts to look at. One are those who chose some other birth control method, were not interested in having a tubal. Second group asked for and received a postpartum tubal ligation, and the third group wanted a tubal, but we just never got around to it, and she got discharged without it happening. After 1 year, 22% of the other birth control people were pregnant again, none of the people who got their tubal, and half of the women who wanted a tubal and didn't get it were pregnant. Half. So unwanted pregnancies in half of those women. So unfortunately, even in us, a developed, high-resource country, 50% of pregnancies are unplanned. Now, I don't know if you can read the caption at the bottom, but the dad's saying, and to think the reason we went on that second honeymoon was to get away from the kids for a while. So even under the best of circumstances, stuff happens. ACOG has come out with some very strong statements now to say that they want improved access to tubals, that it should be considered an urgent surgery, citing this 50% rate of repeat pregnancy in the following year and women who request but don't get a tubal ligation done. There's only about a 48-hour window you can do a mini-lap procedure without having to bring them back separately for a laparoscopy. And noting the fact that Medicaid in most states has a really cumbersome process for women to consent for a tubal that is not true of private insurers. And so we have this 2-tiered level of care in that situation. Now, if you have to take care of a woman who's pregnant for a non-obstetric surgery, she needs her appendix out or her gallbladder or ankle fracture fixed or whatever it might be, what drug would you avoid? And I would say most people would almost immediately say benzodiazepines. She can't get any midazolam. So why is that? Are benzodiazepines teratogenic in pregnancy, or are they safe to use? So I'll give you a sample case here. You're taking care of a woman who's 12 weeks gestation. She's going to have general anesthesia for a cervical cerclage procedure. It's only about a 20-minute case. She is really anxious. She's lost 2 pregnancies before this, and she is very worried about what's going to happen with this pregnancy. So she asks you for some sort of anxiolytic or sedation before she goes to the OR. So way back in the mid-'70s, these 2, they're actually letters to the editor, were published. They were observational studies noticing that there was an association between maternal exposure to benzodiazepines. And think about what we had in the 70s. We didn't have midazolam. So we're talking about Valium and Librium that these women were taking. And cleft lip and palate in their offspring. So first thing you ought to ask yourself is, why are all these pregnant women on Valium and Librium? So if you look back, a lot of it is things like alcohol withdrawal. I mean, there's a lot of polypharmacy going on here. This was not the only thing they were typically taking. So later work looked at this again in a better, more prospective fashion and did not find those results. So this is one of them. It's published in the New England Journal. 600 infants who had a cleft lip and palate compared to almost 2,500 who did not, had some other congenital anomaly, and the risk of clefts was no different if the women were or were not exposed to benzodiazepines. And you can see for cleft lip and cleft palate alone, the confidence interval crosses 1. Similarly, this was an NIH-supported prospective study, same findings, the risk of cleft associated with Valium use, confidence interval crosses 1, no difference between the exposure groups. And more recently, there's this meta-analysis, 7 cohort studies, over 1,000 infants who were exposed to benzodiazepines, no increased risk of any major malformation or specifically oral clefts. And cleft lip and palate are the 2 that were initially associated. And their summary was that even when the worst case scenario is assumed, benzodiazepines do not seem to be major human teratogens. Well, fast forward, ACOG has a series of documents called their Clinical Expert Series. And their Clinical Expert Series on teratogenicity goes through every medication you can possibly think of to look at whether it should or should not be used in pregnancy. And in their section on anxiolytics or benzodiazepines, they state there is no evidence of significant risk of teratogenicity, that initial findings of clefts have not been confirmed by long-term follow-up studies. The overall results are reassuring, no adverse effects on neurodevelopment. Now, as a side note, I'm not even going to talk about fetal anesthetic neurotoxicity. That's a whole other hot item out there that we're working through, but nothing in terms of congenital anomalies. And they actually now recommend it for women with hyperemesis. So women who are struggling with hyperemesis gravidarum or severe morning sickness, they actually recommend she be placed on an anxiolytic if other more routine antiemetics are not being helpful. Okay, let's shift gears and talk a little bit about analgesia for labor and how that's changing in our practices. Remifentanil is kind of the hot new drug everybody wants to talk about for labor analgesia. So is it safe to use on labor and delivery? Are there any other circumstances we'd put somebody on a Remi infusion out on the floor and walk away and leave them? I don't think so. So I would say maybe, maybe not, depending on whose work you look at. Now, Remi has a lot of favorable characteristics that seem like it should be good for labor analgesia. It's very fast onset, short duration. You don't need to have functional liver or kidneys because it's inactivated by plasmasterases. So our patient with HELP syndrome and 20,000 platelets and a high creatinine and abnormal liver function test, that should be a good candidate. It does have inferior analgesia to an epidural, obviously, but it's still pretty darn good pain control. VAS scores were around 4 after 30 minutes of use. Postpartum satisfaction rates were very high in the women who received it. But you do need to make plans for what monitoring you're going to do on labor and delivery. Who's going to be looking at her to see if she's getting too sedated, if she's desaturating, if she's apneic? Now, what policies are you going to put in place for your nurses? Because you're going to be the one writing those and identifying how the nurses need to take care of these patients. So I'll show you a couple things that have come out just recently. This was a study where they were looking at, well, what monitoring should we be doing? What respiratory variables are most sensitive to pick up a woman who is having respiratory depression from this remifentanil? One of the things they found is that over 50% of women did become apneic while they were receiving Remi. Over 50%. And I'm quite sure that, those of us who've used it in the OR have at least once overstepped our bounds and had a patient become apneic while we were using remifentanil. The thing that detected the most apneas in these women was end-tidal CO2 and respiratory rate. Who's got that on their labor and delivery unit? I mean, what labor room has end-tidal CO2 monitoring capabilities? Saturation, on the other hand, so having a pulse ox, which is what we normally do, detected less than 15% of these apneic women. And no monitor was as reliable as just having somebody one-on-one standing at the bedside, exactly what we do in the OR, but what never happens on a labor and delivery unit. So this was a survey that they sent out to all academic practices that had a residency program and an OB anesthesia rotation, and they asked, how often have you used remifentanil for labor analgesia in your patients? And you can see not very often. Only 15 centers had used it, and that was less than 5 times. Only 4 had used it more, 10 or 20 times. None had used it more than 20 times. So none of us have much of any experience with it. But along with the survey, they found that most required one-to-one nursing. Many of our labor and delivery units are way too busy for nurses to stand one-on-one with a patient in the room. And most use pulse oximetry as their monitor, which, as we saw, isn't really a very good monitor. Among those centers that had tried it, they had 9 cases of respiratory depression, 2 cardiac arrests due to their analgesic regimen. So they estimated somewhere around a 10% maternal morbidity rate. What else do we do in our practices that we think a 10% morbidity rate is okay? So no consistent method of drug delivery or PCA use. So I, in my own mind, am not quite sure that remifentanil is ready for prime time or that LND is an appropriate site in which you would want to use that drug. What about nitrous oxide as another non-neuraxial option for labor analgesia? Is it worth your time and effort to go through all the hoops you have to jump through to get that as an option for labor analgesia in your hospital? Well, I would say possibly, something to consider, but you need to know your patient mix. So, for example, in my hospital, 35% of our deliveries are midwifery. And that's a very popular item for their patients to know that it's at least an option for them. And you need to know your billing rules. Is this something you can get paid for if you're going to go through the effort of getting it available? So nitrous oxide is used pretty much everywhere else but the United States. So in Great Britain, virtually every woman will get nitrous oxide at some point during her labor. Same for the Scandinavian countries, Australia. So there's a lot of history of it being used out there. Very minor side effects for the mom, maybe some dizziness, occasional nausea, no known fetal effects. And again, I'm not going to get into anesthetic neurotoxicity today. Very rapidly reversible. If she doesn't like the side effects, she takes the mask off her face and it's gone in 2 or 3 minutes. Different than opioids side effects. We've found you can use it as an alternative to a neuraxial block for other painful procedures like an external cephalic version for a breech baby, a woman who had an unmedicated delivery but now has a 3rd or 4th degree repair that needs to get done. No relevant occupational exposure for the nurses. They have little badges the nurses can wear if they want to that will pick up their nitrous oxide exposure. We use that, other centers have, and it's basically 0. Satisfaction scores are very similar to those with an epidural, even though the pain scores don't change much. Nitrous oxide is an odd drug in that way. You look at them, and they don't look like it's helping at all. And then you ask them later, it's like, that was great. It was so helpful to me. I got such benefit. And you're like, what did I miss? And it does meet CMS guidelines for conscious sedation. So if you want to maintain that as anesthesia provided, you can bill for it, and it's billed just like other forms of labor analgesia in terms of base units and time. On the other hand, if you don't want to deal with it, you can hand it off to your midwifery service or OB or whatever you want to do, and it's supervised like any other kind of conscious sedation in the hospital. So this is what it looks like if you've never seen it. It's kind of the size of like a sonosite ultrasound you might push around the hospital on a cart. It has a one-way valve in the mask, so the only way she gets nitrous is to hold it tight enough seal against her face that she can inhale and open that valve, thus the lack of exposure. This is kind of what we found from introducing nitrous on our unit, and I'm comparing it to UCSF because they've had it for decades. They have a lot of experience with it. About 20% of our patients will ask to use nitrous oxide at some point. Again, we have a large midwifery service in my hospital. About 65% of them will eventually transition over, so these are often very early labor patients that want to try something else for a while and get their epidural later. About 75% of our patients get an epidural overall in our practice. We've had no adverse events. And same thing for UCSF, who's had it for a much longer time. Well, going now into epidurals for labor analgesia, I think we're all very protective of this is how I do my procedures, right? This is how I want you to do it. I'm teaching you today, and you're going to do it my way. So one of those is air versus saline. So how do you do your loss of resistance for your neuraxial blocks? Is there a difference? Is there some difference in the quality of analgesia or other things that are going to happen depending on which you choose? Probably not. Probably doesn't make any difference whatsoever as long as you stick with the technique you're accustomed to. So this was a big meta-analysis, 5 studies, over 4,000 patients. They looked at air versus saline, couldn't find any difference in adverse outcomes, things like catheter insertion, paresthesias, intravascular catheters, dural puncture, patchy blocks, etc. This was a study from Brigham and Women where they looked at their, they have a very high volume delivery service, about 15,000. They have a lot of different providers, so they have people doing things all different ways. But about half of their anesthesiologists used air, about half used saline for loss of resistance. Same results in that there was no difference in block success rate between the groups, IV intrathecal catheter placement, need for epidural catheter replacement. But What they did find is if you made the anesthesiologist switch from what they like to do. So I'm an air person. I learned with air. I've always used air in my practice. If you make me use saline, my outcomes are much worse. So if the anesthesiologist got to use their preferred technique, they made fewer attempts to get in the epidural space. They had fewer paresthesias placing it, so found midline better, and fewer wet taps, significantly fewer wet taps. So I think the moral of the story is do whatever you want, but do it the same way. And then there's combined spinal epidural analgesia, which some practices have adopted, many have not. Is that preferable to epidurals? Well, there's pros and cons for both techniques, but CSE catheters have definitely been shown to be more reliable and need replacement less often. Are complications more common now that we're doing a dural puncture as well? And the answer to that is definitely no. So CSEs are where you place the epidural using whatever loss of resistance you like, and then you use the epidural needle as an introducer to pass your spinal needle through till you get CSF. And then you do or don't put medication in, depending on what you're doing here. Big Cochrane review, 19 trials, no difference in maternal satisfaction between a combined spinal epidural and epidural, how well they could move around during labor, modes of delivery, newborn, post-dural puncture, headache, hypotension, etc. They did find that CSEs were faster, makes sense, right? Spinals come on faster than epidurals do. Less need for rescue analgesia, and I'll show you another study having to do with that, and less urinary retention, which is also a big deal in labor. So this was a study from Mary Birch down in San Diego. It's a busy private practice. They looked at 800 women who were randomized to either get a combined spinal epidural or an epidural, and these were all placed by experienced anesthesiologists. These were not learners. These were people who have been doing this forever in a very busy practice. They didn't find any differences during the second stage of labor while she was pushing or at the time of delivery. But the combined spinal epidurals gave better pain scores throughout the first stage of labor, so from the time of placement until she was completely dilated. And fewer of the CSE patients needed top-ups. And that's a big deal. If you're on covering labor and delivery by yourself in a busy practice and you got 5 epidurals running, you do not have time to keep going back into the room and giving top-ups. So if this is a way to make that work more effectively, that's a great thing. This was a retrospective look, large number of CSEs or traditional epidural catheter placements, and they found that catheter failures, need for replacement, was twice as common in the epidural catheters than the CSEs. And that's a very consistent finding over and over. The hazard ratio is 0.58%, so fewer of those CSE catheters failing. And among the catheters that did fail in either group, no difference in failure time course, and the CSE did not delay recognition, which is something we've been worried about. So this is a Kaplan-Meier survival curve. The epidural group is on the bottom, the dotted line, the CSE group's on the top, and you can see almost from the time of placement, it's the epidural catheters placed the conventional way that are more likely to fail over time. The CSEs are more reliable. Now, there's this new thing called a dural puncture epidural, which is basically popping your spinal needle through the dura, but not putting any drug in, just to kind of make sure you're in the right place and leave a little opening, perhaps, for more local transit. So is that advantageous, even if you're not going to put in drug? And the answer seems to be yes. This was a study from earlier this year. They found that the speed of pain relief was fastest in the CSE group, but the dural puncture epidural was still faster than a conventional one, so you got your patient comfortable more quickly. There were few epidural top-ups required when you did the dural puncture, even without medication, and there were fewer side effects, so you had less itching and hypotension than with the CSE, and you had less asymmetric, patchy, one-sided kind of blocks than you did with the epidural. So even if you're not going to put medication in the intrathecal space, it's something to consider whether you might want to just pop the spinal needle through anyway, make sure you can see CSF, confirm you're in the epidural space, and then thread your catheter. Another new maintenance technique we have is this programmed intermittent epidural bolus, which means that your epidural pump is programmed to give, say, 5 cc bolus every 30 minutes, rather than a drip, drip, drip of 10 cc's an hour. So is that better than a continuous infusion? Maybe, kind of depends on who you ask. A lot of controversy about that right now. So this was a systematic review, 9 randomized controlled trials comparing intermittent bolus to continuous infusion. No difference in most variables between the two. The intermittent bolus had a little bit lower bupivacaine use overall in labor, but not much to speak of, probably not clinically relevant. Little higher scores for maternal satisfaction. This was a pig model, so an animal model, where they were looking at the spread of epidural local anesthetic, whether you're giving it as a bolus or, again, the drip, drip, drip of a continuous infusion. And not surprisingly, when you bolused it, it spread more. In labor, when you get called to the bedside because a patient needs a top-up, what do? Give a bolus, right? 5, 10, 15 cc's, whatever seems appropriate. You don't just turn up the epidural infusion and walk away. So it kind of makes sense, and that's what they say in their conclusions. It's reasonable to assume that patients who receive epidural but are getting pain because the band of analgesia is too narrow for them might benefit from an additional bolus, and why not have the pump do it rather than you having to go to the bedside and do it? Okay, anesthesia for C-section. This study's gotten a lot of talk this year because it so goes against what we've learned about maternal physiology. So is left or right uterine displacement really necessary when you're doing a C-section? Maybe not. Maybe not the way we practice in this day and age. And wouldn't that just thrill our obstetricians if we didn't have to tilt the bed while they're working? So it took 100 healthy women having a spinal anesthetic for C-section. They all got a crystalloid coload, and what that means is you give your fluid bolus at the time the spinal is being dosed, not ahead of time. And they got a phenylephrine infusion that was titrated to keep their blood pressure to 100% of whatever their baseline was. And then when they were laid back down on the bed, they were randomized to either get a wedge under their hip or be completely supine. No difference in umbilical cord gas, pH, or base deficit in the babies. So maternal tilt does not improve neonatal acid base status, which is kind of why we thought we were doing it. But what they did find is the phenylephrine requirements were higher in the women who were supine, and their cardiac output, which they were measuring non-invasively, was lower if they were supine. But in a healthy mom with a healthy baby, if we do the other things to maintain blood pressure, it doesn't seem to matter for the baby's outcome whether we have that mom tilted or not. Well, which pressor should we be using? Which is going to provide the best outcome for mother and baby when we're treating hypotension from a spinal? For years and years and years, it was nothing but ephedrine. That was a drug of choice for a pregnant mom. But now we think it's alpha agonists, which would be phenylephrine in this country. So why is that? A lot of studies of healthy women with a healthy baby having an elective C-section with a spinal anesthetic. Randomized to ephedrine or an alpha agonist, and the alpha agonist did the best job of controlling maternal systolic pressure, thus she had less nausea and vomiting. Nausea and vomiting is miserable for a woman having a C-section. And when they looked at the babies, the umbilical pH was better, the base deficit was less, and the Dopplers, the uterine artery Dopplers, looked the same in both cases. So we are not causing uterine artery vasoconstriction by using phenylephrine. Well, why is that? Why were we wrong for so many decades in thinking that ephedrine was the best drug to use? Well, this was a nice editorial written by Ed Riley at Stanford pointing out that ephedrine's primarily a beta agonist drug, right? And so you are increasing that baby's metabolic rate. You've probably all seen on the fetal monitor strip, you give a dose of ephedrine and the fetus becomes tachycardic for a period of time. When we give an alpha agonist after a spinal, we are not causing vasoconstriction. We are just bringing her preload and afterload back to normal. And maternal sensitivity to vasoconstrictors is much less in pregnancy, especially in the uterine arteries, because teleologically that would protect the fetus from having decreases in uterine blood flow. So this study was designed to look at whether ephedrine actually does those things to the fetus. Does it cross the placenta and stimulate hypermetabolism in the fetus? So they looked at cord-blooded delivery, 104 women, again, healthy mom, healthy baby, elective C-section under a spinal. And ephedrine did cross the placenta much more readily than phenylephrine did. The ephedrine babies had a lower pH, higher base deficit like we've seen before, but they also had higher lactate levels, higher glucose, epinephrine, norepinephrine, all the things we think of as a stress response were going on in those babies that got the ephedrine. So overall, the effects on fetal oxygen supply and demand look much better when you're giving phenylephrine. So the other thing we do to try to prevent hypotension after a spinal anesthetic is we give lots of fluid. So is an adequate IV fluid preload going to prevent maternal hypotension after a spinal or an epidural? No, it's not. So this was a nice editorial that just sort of summarized all the data that's out there. So they went through and looked at the studies that had given crystalloid or nothing, that had given crystalloid or colloid as a preload, that had given crystalloid or colloid as a coload, that had given colloid as a preload or nothing. And none of these regimens, no matter how much you gave or when you gave it or which fluid you chose to give, made any difference in the amount of pressor or in neonatal outcome, which is what we're most interested, right? So since none of these regimens is going to prevent hypotension, really all you really want is a running IV so that you can get your pressor in to keep the blood pressure where you want it. What about general anesthesia for C-section? We talked about this a little bit in the resident conference yesterday, but we have worked for years and years and years to try to do as little general anesthesia in obstetric patients as we possibly can. So should we always be avoiding general anesthesia? And I would say no, because regional anesthesia has its own set of issues that we have to deal with. So what's good about doing general anesthesia in OB? Why would we want to do that? Well, for one thing, it's much safer these days. We've got a lot better airway tools, LMAs, video laryngoscopes, and we know how to manage a difficult airway much better than we did in the 70s and 80s. There are emergent situations on L&D that are like nothing else in our practice. A cord prolapse at 3 in the morning when you are sound asleep in your call room makes you move faster than anything else you will ever do as an anesthesiologist. We need to do basic safety principles no matter what kind of anesthetic we are doing for a C-section. Now, the downside of regional anesthesia, and why we probably need to rethink that having such an emphasis, is that if you look at the closed claims project, or we looked yesterday at a series of cases from the doctor's company, claims related to regional are going up while claims related to general are going down. So the most common complication in OB anesthesia now is a total spinal, a high block. Liability claims are also out there for pain during surgery. These are almost always women who had a patchy block and we just couldn't bring ourselves to put her to sleep, so we tried to coach her through it with that whole pain versus pressure nonsense we do. And that's just our own reluctance to convert to a general anesthetic. And because of that, liability claims occur. Similarly, there are also liability claims for neonatal bad outcomes, bad baby cases, because we persist in trying to get that spinal in rather than just putting them to sleep when the baby's having an issue. So in the SOAP SCORE project that we looked at yesterday, this was a 5-year registry. Hospitals around the country submitted their quality improvement documents on all the cases that they did. 5,000 general anesthetics were in there. 1 in 500 resulted in a failed intubation, but there were no deaths, there were no hypoxemic arrests. We are good at rescuing an airway that's difficult to intubate. No cases of aspiration, which has also been one of our big fears. So in modern obstetric practice, these complications seem to be much less severe and much less common. And as I said, the most common anesthetic complication in OB patients is actually a high spinal, so it's our regional anesthetics. Now, is general anesthesia going to become a common choice, something we do a lot for elective OB procedures? No, absolutely not, because our patients and our obstetricians both prefer neuraxial anesthetics, and there's a lot of benefits for mom and baby of doing that. But we also shouldn't refuse or hesitate when general anesthesia is more appropriate to go ahead and move that direction. So last couple minutes, I want to talk about some of the complications and how we manage that or don't manage it well. Informed consent. If you walk into a labor room for a woman who's 7 or 8 centimeters and look at her anxious, in pain, often very out of control, and say, am I going to get informed consent from this woman? You often feel like there's just no way. She's not hearing anything I'm saying to her. So is it of value? Is it going to protect you in a liability claim? Is she remembering anything you're saying? And the answer is yes, yes, and yes. She is absolutely hearing what you're saying. This was a nice review of informed consent in labor and delivery, pointing out that, yes, laboring patients do remember your discussion. We have good evidence that their recall is just as good as any ambulatory surgery patient you do informed consent with, not hindered by pain or by opioids she might have gotten. And, of course, we never give midazolam during labor as an amnestic. If you can do written materials, either on arrival to labor and delivery or in your OB clinics, that's even better. The recall's better in that. And you want to include the common problems she's going to see as well as the disastrous kind of stuff that can happen. Now, legal cases, and a lot of times what people worry about is, well, what if I get sued? How can I prove I really gave true informed consent to this woman? Those cases actually don't exist. There are no legal cases that even speculate that consent obtained during active labor would not be adequate. And there's several reasons for that. One, you did at least try to give information to the patient, and we're never alone in the room, right? There's family members, the nurses there, whatever. Lack of objection. This wide-awake, unpremedicated woman agreed to sit on the edge of the bed, let you wash off her back, and put an 18-gauge needle in the middle of it. And she cooperated while you did that. So there is implied consent in all of those things. It's also very protective. Now, what about this birth plan thing? This woman walks in with a 3-page, single-spaced birth plan with all the things we aren't allowed to say and do and think while she is having her baby. Well, what if it says, doesn't matter what I say, do not let me have an epidural. No matter what I say during my birth process, do not let me have an epidural. What do you do with that when you do get called and she's 6 centimeters and wants her epidural? Well, this was a nice discussion in the ASA newsletter from the Ethics Committee that pointed out that a competent patient has the right to change their mind about treatment decisions at any time in any situation. No advance directive, which is what these birth plans are, can ethically or legally tie their hands. So if she wants to override that at any point in her care, she is absolutely able to do that. And I would say that a woman is really not giving true informed consent about what she wants for pain control until she's in labor. If you've never been in labor, you have no idea what that experience is like until it happens. So birth plans should really not change our care of the patient at all. The last thing I wanted to mention was breastfeeding. And you might say, why in the world do we need to talk about breastfeeding? Does the use of epidural delay or impede women being able to breastfeed? As you know, the American Academy of Pediatrics now says all women should breastfeed for a year if they possibly can. Well, it probably doesn't, but the verdict is still out. Now, lest you're unaware of what's out there in the lactation literature, I'll give you a couple quotes. One of these here you can see in the Journal of Human Lactation. We recommend a reduction in the use of epidural analgesia to enhance breastfeeding. Another one here from the International Breastfeeding Journal, again, in case you're not completely up on these. Women who had epidurals were less likely to fully breastfeed their infant in the first few days after birth and more likely to stop in the first 6 months. So we don't have much literature to support or refute those comments. There's a couple studies from about 10 years ago that correlated high epidural fentanyl doses with lower rates of breastfeeding, somewhere around 150 mics of fentanyl over the course of labor. However, we want to have fentanyl in our epidural solutions, right? Because it minimizes motor block, it gives us better quality of analgesia, so we're not going to give that up. So the recommendation really became, well, try to at least limit fentanyl boluses and, use your lactation consultants if you have them. Well, just in the last couple months, this study came out. They took 345 women who expressed their intent to breastfeed their babies when they came in, and their epidural infusions were randomized to either have no fentanyl, a low dose, just 1 mic per cc, or our usual dose, 2 mics per cc, in their bupivacaine labor epidural infusions. No difference in the groups between who was still breastfeeding at 6 weeks postpartum, and very high success rates, as you can see. And of those who did decide to discontinue breastfeeding, they were able to look back at the maternal and cord blood levels of bupivacaine and fentanyl, and there was no difference between the ones who continued and the ones who stopped. So this is probably our best evidence we have so far that no, epidurals do not impact the incidence of breastfeeding. So I would say if you have a motivated mom who really wants to breastfeed and a motivated baby who is interested as well, that her choice of labor pain relief is probably not going to make a difference in that process. And with that, I'm going to stop and again say thank you very much for having me. It's been a great visit. I've really enjoyed it.
Joy, that was awesome. Thank you. So comprehensive. I'm sure there's some questions. Here, Judy.
Any questions, or I'm happy to stay around too. Hi, Judy.
Hi, how are you? I just have two questions. Number one, we are in the process of, I think, trying to introduce nitrous oxide, and I'm curious what your experience has been in terms of timing of the epidural, since still a large percentage of your patients end up with an epidural. Mm-hmm. In terms of placing the epidural later in the later in the stages of labor, have you noticed any increased risk of difficulty with placement because they're not able to sit still, or any other issues?
Actually, the nitrous helps with that, so we actually have them keep using it while we're placing the epidural. And so they can keep breathing the nitrous while we sit them up and get their back prepped and until they start getting pain relief from that. The two groups of patients we've found use it the most are the primips who are 2, 3, 4 centimeters, didn't think they wanted an epidural, are still not quite ready to make that commitment and just want to try something else first. And the woman who roars in at 9 centimeters and just needs something to give her over the hump of pushing before she has her baby. In between, no, I don't think there's much interest. And even our nurses, who are wildly enthusiastic initially, have kind of started counseling the patients about, if you're thinking about an epidural, let's just go ahead and do that. But I think in those two groups of patients, it provides an advantage. And I can tell you the other thing it does was just a huge brownie points for the anesthesiology service, because midwives came to us and asked if we would help them get it through P&T committee at the hospital. So we didn't have it, and there's a lot of skepticism. In fact, P&T committee wanted to know why we were using an experimental drug in a vulnerable population. Like, everybody else in the world does this. It's probably okay. And so it did take some doing, actually, to get it accepted. But it made us like the heroes, because the midwifery service thought we were just the greatest thing since sliced bread, because we helped them get this thing for their patients. And what they were seeing is patients would come in for a prenatal visit and say, I'm thinking about delivering at your hospital, but I want to know that I'd have nitrous oxide available to me. And so in terms of increasing their practice and for the hospital increasing that business, they wanted to have this available. And that makes it as much a marketing tool as anything else. And that's important, too, realistically.
Yes, a couple of questions. You mentioned a technique I'm not familiar with, intentional dural puncture of an epidural followed by epidural dosing. What is the incidence of post-dural puncture headache with this technique?
Mm-hmm. So most of the kits have a 27-gauge pencil point needle. So because you have that TUI as your introducer, you can use a tiny needle that you wouldn't be able to really do a spinal with otherwise, because it's just too flexible. And so the dural puncture rate just from a 27-gauge pencil point needle is vanishingly low.
I see. I misunderstood the technique. I thought it was actually an intentional dural puncture with a TUI needle.
No.
So that is not correct.
The introducer and the spinal goes through the drum. Yeah.
Okay.
And interestingly, several teaching hospitals have shown it lowers your wet tap rate. And I don't know if you've ever taught a learner how to do an epidural, but they'll often, kind of be hesitantly working through the ligaments appropriately and kind of get a loss, and they look at you, it's like, was that it? Am I there? And you're like, I don't know, my hands aren't on the needle. But what you can do is say, well, let's pop that spinal through and see what happens. And if you get the dural puncture and there's CSF coming back, it's like, we're not going any farther. Whereas before you'd say, no, I don't think that was quite it. Let's keep going, and bam, now you got a wet tap. So most studies have actually shown the wet tap rate comes down, and then thus your overall headache rate and need for blood patches goes down.
Thank you. My second question is the scenario of a non-urgent C-section and the labor epidural is not working before incision. It's not adequate. In terms of, say, deciding to do a spinal and then dosing the spinal, what's your recommendation?
So, by the time we've figured out the epidural's too patchy and it's not going to be adequate, a lot of times the belly's prepped, the drapes are up, and the surgeons are standing there scrubbed with a scalpel in their hand. And I think it's realistic at that point to lean over to the patient and say, I don't think this epidural is going to make you comfortable enough for the C-section. We have two choices here. And if you thought it was going to be patchy anyway, even have that conversation a little sooner. And she'd say, I would rather just go to sleep. Just go to sleep. However, if you and she feel like it's a better idea to proceed with a neuraxial, I think that's a great time to use the combined spinal epidural because you can start with a lower spinal dose than you might otherwise. Maybe you just give 1 cc of the hyperbaric bupivacaine. And then you still have an epidural catheter available, so if it only gets you halfway to the level you need, you have that backup that you can add some lidocaine to it and raise the level up to a T4 level or whatever you want. So I think that's a nice compromise versus a one-shot spinal where you have to pick a dose, go with it, and hope it's not too low, too high, and just right.
Thank you.
Thank you for that excellent talk. I was wondering if you could comment on your practice about reactivating labor epidurals for postpartum tubules. And then I also had a question about your opinion on things like walking epidurals, which I think are uncommon but occasionally done in the OB practice.
That's more marketing, by the way.
Okay, gotcha.
Our hospital offers walking epidurals. You should come deliver here. So for tubules, our typical cocktail is 100 mics of fentanyl in the epidural and 20 or 30 cc's of 3% chlorprocaine. And we use 3% chlorprocaine because it's the fastest to activate, so you know really quickly if that epidural is going to be adequate or not. And it only lasts for 45 minutes. You're doing a 20-minute surgical procedure. So to use lidocaine for that, you've now confined that woman to the PACU for hours on end until her block resolves versus having it resolve quickly and she can get back to her life as a new mom. So that's what we usually would do. In terms of walking epidurals, I think that's a nice use of the CSE also. So what we do, our protocol for the patient who thinks at least she wants to ambulate, is to put 25 mics of fentanyl in the spinal dose of our CSE, start up the epidural infusion, our usual infusion, at 5 cc's an hour instead of the usual 10 we would do. And then there are ACOG guidelines for intermittent fetal monitoring. When they get their intermittent fetal monitoring every hour, the nurse also has to do a set of orthostatic blood pressures, and the patient has to show she can do a knee bend. And I don't mean a squat on the floor knee bend, but, you can bend and you can straighten yourself back up to prove she doesn't have motor block. And then we tell them, at some point as your labor goes on, this is probably not going to be enough. So you let us know when you feel like you need more, and we'll dose it up. And probably at that point, then you will need to stay in bed because your legs are going to get a little wobbly. And depending on the patient's tolerance and really what she wants out of it, some of them go all the way to delivery with nothing but that, and some people get to 6 centimeters, like, enough, I'm done here, and off you go.
I just had one question. I know you brought this up yesterday in the resident lecture, but the use of TAP blocks for the patients after C-sections. Do you guys use it that much, or what's your thoughts on using TAP blocks?
Much on OB. We probably use it more in our ambulatory surgery center, but I think the time it's useful is for the stat section under general. So before they wake up, you can put in TAP blocks with ultrasound, or when they get to PACU, you can do that and provide them good pain relief and minimize their use of an IV PCA. When you put it head-to-head, neuraxial morphine or TAP blocks, the neuraxial morphine definitely provides better quality of analgesia. Has more side effects, but the quality of analgesia is better. So I think the main advantage is the patient who had a general and never had a chance to get a neuraxial block.
Sorry, just one quick follow-up question to that. In my experience, most of the GA sections you end up doing are generally unexpected. And there is not necessarily time to do an informed consent for a post-operative TAP block while being concerned about fetal bradycardia or whatever else. So how have you approached that issue Like, do you feel that it's necessary to get informed consent to do a tap block after a general anesthetic? Because theoretically, I mean, that's usually what we would do for, if it was planned for some other procedure.
Right. I think if you're comfortable that verbal consent was adequate, and that's a judgment call, depending on how frantic the patient is at that moment because their baby's in trouble and such. But if you feel like you can at least go through we're going to put numbing medicine in your stomach to try to help your pain control before you wake up from surgery, is that all right? Whatever you feel like would be enough. Then I think verbal consent is fine. If not, you can treat it as a rescue block in the PACU and talk to them about it when they wake up. If their pain control is not adequate on parenteral opioids, that's something you can add.
Any other questions? All right, thank you so much.
Yep, you're welcome. Thank you.